Hello, a very warm welcome to you to this Med-All education program. If this is the first time you are joining a Med-All program, you are especially welcome. Med-All exists to make medical education radically accessible to every colleague everywhere, always free and always open access. We hope you find today's CME session useful for your practice. My name is Sudarshan Rajagopal, and I'm a cardiologist and physician scientist at Duke University School of Medicine. I will be joined on this program by my colleague, Dr. Kelly Chin, Director of the Pulmonary Hypertension Program and Professor of Medicine at UT's Southwestern Medical Center in Dallas, Texas. Before we begin, it is important that we share our disclosures with you. So you can take a moment and review all of this. The learning objectives for today are: 1, describe the major pathophysiological pathways underlying PAH and how they inform therapeutic targets. 2, apply current international guideline recommendations to ensure evidence-based use of approved PAH therapies. 3, differentiate between monotherapy, dual therapy, and triple therapy approaches, highlighting their appropriate use in clinical practice. 4, determine when and how to escalate therapy in patients with PAH, using risk stratification and clinical response to guide treatment intensification. And 5, develop personalized treatment plans that integrate guideline-directed therapy, pathway-based rationale, and patient-specific factors to optimize outcomes. We will have some polls in today's session. You'll be able to answer them using the chat on the right side of the screen or using the chat icon on mobile. If you place the video in full screen, you will need to exit full screen video to answer the polls. We also have some time for questions and answers at the end. Please put any questions you have in the chat box. Now let's get started. Myth 1, the traditional stepwise approach is still sufficient. Here are my disclosures again. The learning objectives of this talk are to describe the major pathophysiological pathways underlying PAH and how they inform therapeutic targets, and apply current international guideline recommendations to ensure evidence-based use of approved PAH therapies. Let's start with a polling question. In patients with newly diagnosed PAH and evidence of elevated pulmonary vascular resistance, which of the following best reflects the key pathophysiological pathways that drive disease progression and form the basis for current therapeutic targets? A, excessive activation of the renin-angiotensin-aldosterone system and reduced endothelin-1 signaling. B, overexpression of nitric oxide synthase and increased prostacyclin production. C, dysregulation of endothelin-1, nitric oxide, prostacyclin, and activin BMP signaling pathways. D, primary involvement of the sympathetic nervous system with reduced catecholamine clearance. E, isolated pulmonary venous remodeling without arterial involvement. Okay, we'll move on. So we'll start with a case. This is a 55-year-old man with type 2 diabetes and obstructive sleep apnea who presented to the ER in December 2023 with chest pain. He had a CTP study that showed no PE, but mosaicism and air traffic. And he also had a transthoracic echocardiogram that had signs of pulmonary hypertension. There's the short axis view here, and you can see that there is some septal flattening. Here's a Doppler of the RV outflow tract, and you can see that there is a notching of this outflow tract Doppler, which is consistent with significant precapillary pulmonary hypertension. And here's the 4-chamber apical view, and you can see that the right ventricle is moderately enlarged, in fact, larger than the left ventricle, consistent with pulmonary hypertension, precapillary pulmonary hypertension. Now, at that time, the patient was referred to see an outpatient pulmonologist. They saw that pulmonologist the next month. He had PFTs that demonstrated mild restriction and a mildly decreased DLCO. So he was scheduled for right heart cath based on the findings on his echocardiogram that were concerning for precapillary pulmonary hypertension. At right heart catheterization, the following hemodynamics were obtained. The RA was 3, RV was 65/5. The PA pressure was 68/24, a mean of 39. The pulmonary capillary wedge pressure was 7. Cardiac output of 5.2, a cardiac index of 2.5 liters per minute per meter squared, and a PVR that worked out to be 6.2 Wood units. So these are all findings consistent with precapillary pulmonary hypertension and consistent with his diagnosis, clinical diagnosis of pulmonary arterial hypertension. He had no response to nitric oxide. Other information, he endorsed WHO functional class 3 symptoms. He was short of breath in the shower and getting dressed. His NT-proBNP was 551 picograms per milliliter. His 6-minute walk distance was 250 meters. So in this patient who underwent other studies, and again, his clinical diagnosis is now PAH, what treatment options do we have? And today we really have 4 pathways that we can target. And I'll walk you through this from left to right. We have here the endothelin pathway, where pulmonary arterial hypertension is associated with increased levels of endothelin-1 that binds to its receptors on smooth muscle cells. This promotes vasoconstriction and pulmonary vascular remodeling. So we can block this with ERAs, endothelin receptor antagonists. Now, the second pathway here is the nitric oxide pathway. Nitric oxide is secreted by endothelial cells, and then in smooth muscle cells, it activates soluble guanylate cyclase to generate cyclic GMP, and that leads to vasodilation and improved vascular tone. And this pathway can be activated directly with an SGC stimulator, such as riotegrat, or by inhibiting the breakdown of cyclic GMP by inhibiting phosphodiesterase 5 with inhibitors, such as sildenafil or tadalafil. Then we have here the prostacyclin pathway, where prostacyclin is also secreted by endothelial cells and binds to its receptor on smooth muscle cells, the IP receptor. This will increase levels of cyclic AMP that promote vasodilation and positive vascular remodeling. And so this we can target with prostacyclin pathway agonists, or TPAs, as shown here, that all improve pulmonary hypertension. And then our most recent pathway that's been identified for treating PAH is through inhibiting the activity of activin. So activin binds to its receptor and promotes abnormal pulmonary vascular remodeling that counteracts the beneficial signaling of the receptor BMPR2. BMPR2 is a receptor that is the most common mutation with loss of function mutations in hereditary pulmonary arterial hypertension. So by blocking activin with activin signaling inhibitors that will literally bind activin and prevent it from signaling through its receptor, this is thought to rebalance signaling and effectively increase signaling by BMPR2, which acts as a quiescence factor and promotes normal pulmonary vascular quiescence and counteracts the abnormal pulmonary vascular remodeling seen in PAH. So you can see here, we have a range of therapies, some of which are thought to act primarily as vasodilators, but also have some anti-proliferative effects. And then the ASIs, such as sotatercept, which are really thought to rebalance the pro and anti-proliferative signaling in these smooth muscle cells. So that's good to know. We have these 4 pathways that we can target with therapies today, but how do we use them? So this comes to our next polling question. In patients with confirmed group 1 PH, that is PAH, who are not high risk at diagnosis and have intermediate risk features, e.g., WHO functional class 2 to 3, an elevated NT-proBNP, and a reduced 6-minute walk distance, which initial treatment strategy is recommended by current international guidelines? A, start monotherapy with either an ERA or a PDE5 inhibitor. B, begin sequential therapy only after 6 months of observation. C, start triple oral therapy with ERA plus PDE5 inhibitor plus selexipag. D, initiate upfront dual oral therapy with an ERA plus a PDE5 inhibitor. E, reserve combination therapy only for patients with high-risk hemodynamics. All right, we'll move on. So here you see the ERS ESC 2022 pH treatment algorithm, and I'll walk you through this. So once someone has been diagnosed with PAH, we're going to focus on this side, the patients who don't have cardiopulmonary comorbidities. And what is performed is a risk evaluation. And based on the risk evaluation, essentially whether they're lower intermediate risk or identified as high risk, for lower intermediate risk patients, they will start on dual oral therapy with an ERA plus a PDE5. That's a class 1 recommendation. For patients who are high risk, based on their initial presentation, you start with upfront triple therapy with an ERA, PDE5 inhibitor, and an IV or subcutaneous prostacyclin. Now, you then follow them up regularly at 3 months, and then you reassess their risk. And then based on that, if they have not achieved low risk status, you will then add therapy. Now, at the time of these guidelines, there was no activin signaling inhibitor. There was no sotatercept. So it really focused on getting patients to triple therapy if they were not at low risk. And then if they maintained intermediate high or high risk category, you would also refer them for lung transplantation. I will highlight there is one area where patients can be considered to start on monotherapy, and those are patients with cardiopulmonary comorbidities. And there, if there's a concern that they may have significant lung disease, significant left heart disease that's complicating their pulmonary hypertension, that you would start with initial oral monotherapy to ensure that they tolerate it and then follow them up regularly. But I will say, this is, while clinically this does happen, it's when patients present like this patient here with significant hemodynamics, even patients who have risk factors for left heart disease, such as hypertension, diabetes, coronary artery disease, those patients have been shown to benefit from upfront dual therapy in the clinical trials. Now, we do have some guidelines that have been released since sotatercept has been available, and that's in the World Symposium for Pulmonary Hypertension Treatment Algorithm. And everyone will say, these are not guidelines, this is a consensus document. But, and this, Dr. Chin was the first author of this treatment algorithm. But you can see here, it's a very similar approach with an initial risk assessment for these newly diagnosed patients. If they're high risk, it's upfront triple therapy. If they're not high risk, it's dual oral therapy with an ERA and a PDE5 inhibitor. There's a follow-up risk reassessment at 3 to 4 months. And again, for patients who are low risk, they've achieved their goal, you're done. You don't need to add therapy. But if there's anything else, you have to add therapy. And that can range from adding ASIs, such as sotatercept, to maximizing their other therapies, essentially until someone is on what we call quad therapy, quadruple therapy, where patients, if they've not reached low risk status, you're going to have them on an ERA, PDE5 inhibitor, prostacyclin pathway agonist, and sotatercept. And for patients who, despite that 4-drug therapy, are still intermediate high or high risk, you would then refer them for lung transplant evaluation. So for this patient, his risk assessment, he had WHO functional class 3 symptoms, that's intermediate, NT-proBNP of 551, intermediate, a 6-minute walk distance of 250, intermediate. His right atrial pressure was 3, that's low. Cardiac index of 2.5, that's also low risk because it's preserved. So this patient falls into an intermediate risk category based on these parameters. And again, as I will mention, in patients who, a subset of patients may have PAH, but with a high comorbidity burden. And in this setting, initiating therapy as monotherapy may be preferred in order to monitor for tolerability in response to therapy. And this, again, for patients who have there's significant concern for left heart disease, they have risk factors for diastolic dysfunction, or if they have significant lung disease. Now, what's our data that guides the upfront use of an ERA and a PDE5? It's the AMBITION study, which is now more than a decade old and was really a game-changing study that changed our approach to therapy in PAH. And in this was the effect of ambrisentan plus tadalafil versus monotherapy. And so they compared ambrisentan plus tadalafil to tadalafil alone and ambrisentan alone. And so that's the pooled monotherapy group, or those two, ambrisentan alone and tadalafil alone. And here you can see the combination therapy group has a significantly reduced risk of events with a hazard ratio of 0.50. And again, this benefit was still seen in patients who had risk factors for left heart disease. And that's what leads to the guidelines recommending upfront dual oral therapy for the vast majority of patients. So this patient was started on tadalafil and macitentan. He has functional class 2 symptoms now. His 6-minute walk distance is 401 meters, and then T-proBNP of 40, which is normalized. And now his echo, his RV, you can appreciate, is smaller, and now with just mild RV enlargement, but he still has some dysfunction, a TAPSE of 1.9 centimeters. But based on these parameters, this patient has reached low risk status, and we don't necessarily have to add therapy, although there might be other risk factors that would favor the addition of therapy. Myth 2, monotherapy is usually enough. So the learning objective here is to differentiate between monotherapy, dual therapy, and triple therapy approaches, highlighting their appropriate use in clinical practice. And I'll add one more, which is now another common term we use, which is quad therapy. So here's the WSPH treatment algorithm again here. And you can see that after that initial risk assessment, we're going to be providing a follow-up risk assessment. And for patients who have not achieved low risk status, we're going to consider adding therapy. And I'm just going to highlight a few studies that have shown the benefits of adding therapy in this type of situation in patients who have not achieved low risk status. Now, I will say that the majority of these studies were performed before we were doing these risk assessments regularly. So it really wasn't, we really can't say that the patients were all low risk or sorry, were all not low risk. It was based more on the inclusion parameters for those clinical trials, which included functional class and 6-minute walk distance, among other parameters. So here's Seraphin, which is the effect of macitentan on disease progression. And again, 64% of these patients were on background therapy, but this was before the era of upfront dual oral therapy. So you can see 62% of patients were on a PDE5, 5% were on a prostanoid. And you can see that adding macitentan significantly improved outcomes when you're looking at this event related to PAH or death from any cause, showing essentially the benefit of adding an ERA to pre-existing therapy. Now, a similar study was performed with the oral IP agonist, selexipag, in the Griffin trial. Now, here we can see a number of these patients are already on ERA plus PDE5 inhibitor, but only a third. And then 47% were on ERA or PDE5 inhibitor. And you can see, again, adding selexipag significantly improved the event rate compared to placebo, a relative risk of 40%, hazard ratio of 0.60, market improvement. And now with Hyperion, this is sotatercept for pulmonary arterial hypertension within the first year after diagnosis. The majority of these patients were on dual oral therapy, although there were a few patients on triple therapy. You can see adding sotatercept to these patients who had not achieved low risk status when at initial presentation, they're markedly reduced their risk of having an event with a hazard ratio of 0.24. Now, I didn't want to highlight all the other studies of sotatercept, but this is also consistent with the results of the Stellar study, which was in more of an intermediate risk population, and the Zenith study, which was primarily a high risk population. Now, in both Stellar and Zenith, the majority of the patients were on triple therapy to begin with, and adding sotatercept significantly improved outcomes. So we have a large basis for adding therapy. So again, consistent with monotherapy not being enough or dual therapy not being enough for the majority of patients. So with that, I'll summarize my talk. The traditional stepwise approach is not sufficient, right? Standard of care for PAH patients is upfront combination therapy. Monotherapy is usually never enough. As you can see from the studies I highlighted at the end, adding therapy to whatever therapies folks were on, whether it was monotherapy or dual oral therapy or even triple therapy, the treatment is really guided by risk. And we now take patients up to quadruple therapy for patients not reaching low risk status. And that's consistent with the WSPH consensus document. So with that, I'll thank you for your attention. And now I'll hand over to my colleague, Dr. Chin, to take you through myths 3 and 4 of this program.
Hello, I'm Kelly Chen from UT Southwestern in Dallas, Texas, and today we'll be talking about rethinking pulmonary arterial hypertension. My disclosures are here, mostly related to research work in pulmonary hypertension, either on steering committees or clinical research that we do at our institution. All right, starting with myth 4, escalation can wait until worsening. So the learning objective here is to develop personalized treatment plans that integrate guideline-directed therapy, pathway-based rationale, and patient-specific factors to optimize outcomes. So first with a question. In patients with confirmed PAH who show partial improvement on initial dual oral therapy but continue to have intermediate low-risk features as shown, which of the following best reflects guideline-directed next steps to optimize long-term outcomes? A, continue current therapy unchanged as long as symptoms have improved. B, delay escalation until clear clinical worsening or hospitalization occurs. C, switch both oral agents to alternative drugs within the same classes. D, discontinue one agent to evaluate whether symptoms worsen. And E, perform comprehensive reassessment and consider escalation to add-on therapy. All right, let's start with the case. So this is a 42-year-old woman who I met some time ago. She has a history of rheumatoid arthritis on infliximab, and she comes in with dyspnea. She's able to do her ADLs and shopping, but she has dyspnea at faster paced walking or with stairs. So she undergoes a workup, starting first with the dyspnea eval and then working into pulmonary hypertension when nothing's found on her lung evaluation. She also has a normal VQ. Her echocardiogram suggests pulmonary hypertension, and she's referred for right heart catheterization, which is shown on the right, and this confirms PAH. She has a PA mean of 48, normal cardiac output with an index of 2.6, and a very high PVR at 8.7, as is pretty typical of newly diagnosed PAH patients. She initiates guideline-directed therapy with oral combination therapy with a PDE5 inhibitor and an ERA, and she undergoes follow-up 6 and 12 months later. She tells you she's feeling better, and you can see here her functional class, 6-minute walk distance, and NT-proBNP. Her functional class is improved. Walk distance is improved as well, but just a bit, and her NT-proBNP initially improves, but then loses ground. So where do we go from here? She's doing okay. She's not declining. She's even a little better. So the best next step is to do a formal risk assessment using a risk calculator. And there are two main risk calculators that I use in my practice and that have been comprehensively developed. The first comes from the ESC-ERS guidelines and sometimes goes by Compara, which is one of the registries where it was developed. And we'll use it to start with. It is quick and easy, and I have memorized the low risk criteria. So very quickly, I know when looking at a patient if they're low risk or not. She is functional class 2, but her walk distance and NT-proBNP are above these thresholds, which put her into the, if you average this, which is how this works, into the intermediate low risk range. We could also use Reveal, and on Reveal, she has a slightly low systemic blood pressure, and that gives you a point which puts her into the intermediate risk range. There, it also uses functional class walk and NT-proBNP. So now I have some concerns based on her non-invasive testing, but I need a heart catheterization and echocardiogram for a more complete picture. And these are needed because these non-invasive tests sometimes underestimate overall severity, I think particularly in young patients who really would be normally having a much higher walk distance and much lower NT-proBNP, and then also sometimes overestimate because non-pulmonary hypertension risk factors, comorbidities, obesity, arthritis, so on, can also affect these non-invasive measures. So on echocardiogram, we get a lot of information. We're very focused on the right side of the heart, and I'll show the report information that we had, and then we'll take a look at the pictures in a minute. So she has a baseline echo, a 6-month echo, and a 12-month echo. And it's kind of a mixed picture. So I think you could look at this and conclude, well, some things got better and some things not so much. Maybe we're doing okay here. But in reality, this is a very much not at all okay echocardiogram. The pressures did get a little bit better, and the report on the function is that it improved. But you have to be very careful with RV function. It is dependent on whether there's significant tricuspid regurgitation. And if you have a lot of that, and she does, then so much blood's going backwards that in a sense you get an overestimate of overall function. And the most important and concerning thing on her echo is size. Her right atrium is very enlarged, which is highly concerning. And her right ventricle is enlarged and getting better. And in fact, at the very bottom, we get a comment on our reports. How does it compare to prior? And the reading cardiologist says, this is getting worse. The RV is getting bigger. What does that look like? Here is her echocardiogram. We have right atrium, right ventricle, left atrium, and left ventricle. And you don't really need much more than that to say this is not at all okay. Just very, very large right side of the heart, which is a bit discordant from her walk test and NT-proBNP, but we do sometimes see that in younger patients. On heart catheterization, at baseline, we've already looked at that, severe pulmonary hypertension. 6 months looked very similar. Her pressures and PVR had not improved very much. And then by 1 year, we have the highly concerning finding of a drop in cardiac index, where it has come down below the borderline low of 2.6 and 2.7 that she had. Putting it all together can be a little bit tricky because it's not always clear how to adjust points for the imaging in particular. There's a lot of different things to look at, but at the end of the day, unless the heart size and function are both completely normal, a patient is not at low risk based on their echocardiogram. So this is the ESC-ERS guidelines bigger table with all of the different ways that are commonly used to assess risk. And based on this patient would be at least intermediate risk, with the echo showing some very high risk features. So next steps, prior to that catheterization, she had started having some fluid retention, which is also a concerning finding. She was started on diuretics. We, after the catheterization was done and saw the overtly low cardiac index, started talking about parenteral therapy, which is what we were recommending, but discussed options. And she was still thinking about it, interested in probably trying an inhaled prostacyclin. This was some years ago, so these were the only options available at that time. And prior to initiating anything, she had a very severe decompensation. She was admitted with fast heart rate, with some SVT, volume excess, and required ICU admission to the point that urgent initiation of an IV prostacyclin was undertaken. So how did she do from there? Well, I've been following her for a very long time. I actually recently saw her for her 15-year follow-up where we had done another catheterization. We hadn't done one in some time. She'd been doing so well. You can see where we initiated IV therapy, what her PA pressures and PVR did from there. Big drop in PA pressures. PVR came down well under 5, which is one of our goals, and her cardiac index normalized. On echocardiogram, you can see on the left, the one just before IV therapy. This was about a year after IV therapy. Still some right-sided dilation. We did some additional up titration of her IV therapy. And then this was her echocardiogram at 15 years. And it looks pretty good. The RA and RV are still slightly enlarged, but not very big. And interestingly, she's now 62 years old and starting to show some left-sided changes. Her left atrium is a little borderline, and she's got some mild to moderate mitral regurgitation now. So how did we get there, and what would we do different today in this patient? Well, so she did get upfront ERA and PDE5 therapy, but we were a bit slower to add a third agent. So we went from here to this. I think could have been considered for sure at 6 months. She had not achieved low risk criteria, and maybe we would have avoided the decompensation. So take-home points from this case are that intermediate low isn't truly low risk, but lower relative to other patients. Non-invasive testing provides our best assessment of 1-year survival, but it's not complete. Some younger patients may overperform to some extent. Non-PAH problems can also lead to abnormalities, and a more complete picture can be made by adding RV imaging and catheterization. And then finally, timely escalation to hopefully prevent more severe decompensation. All right, moving on to our next myth, feeling better is stable. So this is a patient that I also saw recently. The learning objectives here will be to determine when and how to escalate therapy in patients with PAH using risk stratification and clinical response to guideline-based treatment intensification. So another polling question. In patients with PAH who report subjective symptomatic improvement on combination therapy but remain not at low risk, which management approach is most consistent with current international guidelines? Maintain current therapy because symptomatic improvement indicates stability. B, reduce prostacyclin dose to minimize side effects. C, escalate therapy, such as increasing prostacyclin dose or adding a fourth agent. D, repeat risk assessment annually unless symptoms worsen. And E, transition to monotherapy to simplify the regimen. Okay, so case 2. So this is a woman that I saw in consultation a few years back. She was 34 years old at the time. She had a history of obesity. Her BMI was around 45, and a history of stimulant use, though none in 5 years. She presents for a second opinion. She had been diagnosed with idiopathic PAH, which given the stimulant use history was likely drug and toxin induced. And this diagnosis had been made in 2020. She was started on dual upfront therapy. She improved, but this was modest and did not reach low risk criteria. So after 6 months, subcutaneous treprostinil was added, and her current dose is 20 nanograms per kilogram per minute. At presentation with me, she remained improved, but still symptomatic, and she had concerns about long-term prognosis, which I agree with, particularly given her young age. We need to look closely to see how overall she's doing. On exam, she's comfortable appearing, has clear lungs, no signs of right heart failure, no lower extremity edema. Her blood pressure is 101/75, and she has a heart rate of 92. We do our non-invasive testing. She's functional class 2, I think, walks 377 meters, and an NT-proBNP is 325. So giving her an overall risk assessment, for this case, we're going to use the Reveal Light 2 risk calculator, which is appropriate for follow-up risk assessment. It is a shortened version of the longer Reveal calculator. And you can do this online, or there are downloadable apps that you can do to also assess risk. It has 6 measures, the same functional class, walk, and NT-proBNP or BNP that's used in the ESC-ERS risk calculator. And then it adds systolic blood pressure, heart rate, and GFR. So for this patient, we go through and click on her NT-proBNP level, which was 377. Sorry, her NT-proBNP level, which was 325, her walk distance, which was 377, functional class, slightly low systolic blood pressure, so that gives her a point, and then heart rate and a GFR for an overall risk score of 6, which is in the lower end of the intermediate range. So what does this mean for this patient prognosis-wise? That was her question coming to you. So this is a study from the French registry where they looked at outcomes at follow-up by risk score. So for a Reveal Light 6, this is in the intermediate range, and on the ESC-ERS risk, she's in the low intermediate range, which would correspond to this yellow line right here. So we've got low risk, low intermediate, the orange line is the high intermediate, and the red line is the high risk. And at 1 year, the low and the low intermediate both look pretty good, well above 95% survival there. But look what happens as you follow this out. The low intermediate, up to 40% of patients have died, and the low risk is a mortality risk of around 10% at 5 years. So this is really important to keep in mind, that PAH remains a fatal condition. Even those low risk patients need to be followed closely, and low intermediate is not really doing okay. So as with the prior patient, we're going to take a look at her heart catheterization and echocardiogram. In this case, not as alarming. Her pulmonary pressure has improved to a PA mean of 45. Cardiac index is at 2.3, so slightly low, and she has a PVR of 6.3. And then these are both from her recent echocardiogram. On the 4-chamber view, we can see the right atrium is slightly enlarged, but not very big, and the right ventricle is also mildly enlarged. When we look at the peristernal short view, you can see some septal flattening, the septal bounce that comes across here between the left ventricle and the right ventricle, and again, that mild right ventricular enlargement. So she's coming to us in 2023, and on the double oral combination therapy plus subcutaneous treprostinil at 20 nanograms, which is a relatively low dose. And so in this patient who had a low cardiac index, slightly elevated NT-proBNP, and the echocardiogram that we just saw, we recommended going up on the subcutaneous treprostinil, and actually over quite some time, but eventually over that next year, get up to 63 nanograms per kilogram per minute. You do want to be cautious with this much of a dose increase. We tend to follow up with a catheterization to make sure that we haven't gone too far, which can be manifested both as excessive symptoms, but also sometimes high cardiac output. So if that's starting, if the cardiac index is creeping up, then you've usually reached your limit on how much you can increase this. We also wanted to look for non-PAH contributors. She is obese. We did an overnight oximetry, which we do in all of our patients. It did not show suggestions of sleep apnea. We do some basic labs to make sure nothing's going on there. And then we also refer her to, we have a weight wellness clinic. Her BMI was 45, and that's a concern both because it impacts symptoms in pulmonary hypertension, but also because if she is potentially going to need to be evaluated for transplantation, a BMI above 30 at my center is considered a contraindication to listing, because these patients really do poorly perioperatively if they don't get their BMIs down. And she actually gets started on semaglutide and loses weight over time, which also helps with symptoms. And then finally, a referral to pulmonary rehab. So lots of things to work on that are all guideline-directed recommendations. So then she comes back, it's 2024 now, and we have a follow-up risk reassessment. So just to refresh where we were, we had a patient who had been on combination ERA and PDE5 therapy and then advanced to triple therapy, and she is now coming back for risk reassessment on triple combination therapy. She this time remains at intermediate low risk. So what are our options now in 2024, 2025, 2026? They've increased now. We can add sotatercept, which is an activin signaling inhibitor. We can consider a switch from a PDE5 to riociguat, our soluble guanylyl cyclase stimulator, or if she were not on it, we could add a prostacyclin, but of course not an option in this patient. In her case, because her blood pressure is low, riociguat was not felt to be a good option. It tends to lower blood pressure more. And so we had a discussion about sotatercept. So it was shown across 3 large trials to improve 6-minute walk distance and to reduce clinical worsening in both the Zenith and Hyperion trials, which were long-term outcome trials. The main risks associated with it, it can elevate hemoglobin or cause low platelets. And so frequent monitoring is required there. Can cause bleeding, mainly as nosebleeds, some gastrointestinal bleeding, or even hemoptysis, and it can cause new telangiectasia to form. It may also cause new shunting in the lungs, which may be picked up on bubble study, or pericardial effusion, but both of these have been seen only rarely and in case reports. It's recommended, as we saw on the slide before, for the low intermediate patient where there are multiple options, and for the high intermediate or high risk patient where there are fewer options for these patients. And maximal medical therapy is now 4-drug therapy, including sotatercept and a parenteral prostacyclin. So how did she do overall? So here I have her 2020, 2023, and 2025 follow-up catheterization. And she had continued improvement in her pulmonary pressures with the addition or with the increase in IV therapy and then eventual addition of sotatercept. She had improvement in her PVR down to PVR below 5, which is another goal of therapy. And then a catheterization on the right with improvement in heart size and function. So take-home points for this case: despite feeling better, this patient's long-term prognosis at referral was only fair. PAH remains a highly life-threatening condition, and so patients at low intermediate risk, the word low in that risk status is really only relative to higher risk patients, but is still pretty considerable when you look at 5-year outcomes. From the very beginning, especially in young patients, but really in all PAH, think about barriers to transplant, which was done in this patient with a referral to the weight wellness clinic. And then most importantly, timely escalation of therapy to maximal medical therapy when needed. And this is now 4-drug combination therapy that includes an ERA, a PDE5 inhibitor or riociguat, and a parenteral prostacyclin and sotatercept.
Thank you so much for your attention. Before we move to questions, this is the QR code to claim your CME certificate for this session, which is completely free. If you look in the chat box, you will also find a link to this, and we'll show it again at the end. Now we have some time for questions. All right, question 1. We've traditionally viewed PAH through the lens of vasodilation, nitric oxide, endothelin, and prostacyclin. With the introduction of activin signaling inhibitors, how should we explain this shift from vasomotor control to vascular remodeling to our patients? And does this change our long-term expectations for disease reversal? Kelly, do you want to take this one, or?
Sure, happy to. So lots of words that I'm seeing batted around at various meetings and discussions amongst ourselves and so on. So I think I'm going to start with the idea that the only thing that our older medications do is vasodilation, which I think is unlikely. They are vasodilators for sure, because we see some acute response to them. In fact, IV epoprostenol was used as an acute vasodilator in the cath lab to test for vasoreactivity for many years until we mostly switched to using inhaled nitric oxide, which is safer. But the majority of patients don't show a large reduction in pulmonary pressures with it. And yet, when patients are treated for many months with it, there's a significant percentage of patients who have a much larger drop in their pulmonary pressures and pulmonary vascular resistance over time. And so I think the mechanism of action of sotatercept is very different, but we shouldn't assume that for sure we know that these older medications weren't contributing to vascular remodeling, because in animal models, they do show some reverse remodeling there. And a subset of patients have very impressive improvement in their pulmonary pressures. The problem is that a large percentage of patients don't have enough. And so there's a ton of excitement about sotatercept. So then sotatercept's mechanism of action. I think at the same time as we're learning how beneficial it can be, we're also learning what we don't know about it. There are a couple of case series. These were tiny studies of only about 6 patients each, but 2 separate ones where patients had an implantable pulmonary pressure monitor, one a CardioMEMS and then a different device that's being used in Europe. And they looked at how quickly pulmonary pressures came down in these 6 patients. And for many of them, it was much faster than we had thought. It wasn't the 3 to 6 months that we thought that it would take, because it's all about remodeling, but instead it was happening over days in many of them. So we're still learning a lot. But what do I talk to my patients about? I think the most important thing is what we've seen in the clinical trials. It's the really large reduction in clinical worsening that was seen in long-term studies, even in patients who were already on 3 medications. So a lot of excitement there, but maybe not pinning everything on knowing or thinking we know everything about the mechanisms. All right, so if a patient is already on maximal triple therapy and remains at intermediate risk, is there a physiologic rationale for which pathway we should focus on next? Specifically, are we seeing better outcomes by switching a PDE5 inhibitor to a soluble guanylyl cyclase stimulator versus adding an activin signaling inhibitor with sotatercept?
Well, I think this warrants a large caveat, which is right, we don't have any randomized data here. In fact, I'm not aware of any published data here comparing the 2 strategies. So this is all expert opinion. And so take everything that I'm saying here with a huge grain of salt. I guess the question is, if someone's intermediate risk, right? So if you look at the the WSPH consensus document, right? If someone's still not at treatment goal, they're that sort of intermediate low risk, you could consider switching from PDE5 to SGC stimulator. But what's the data behind the REPLACE study? It's primarily switching from sildenafil 20 milligrams TID to riociguat. And we have data from a German study in Circulation that was published in 2025 showing a significant difference between 20 milligrams TID of sildenafil compared to 80 milligrams TID of sildenafil. And it should also be mentioned that the majority of patients in the REPLACE study were transitioning from sildenafil to riociguat, not tadalafil to riociguat. And if you look at that other population of tadalafil to riociguat, which is in the supplementary materials, there's not a huge difference, even in the point estimate. So I think if you really want to get your bang for your buck, it's by targeting another pathway. And so if I have a patient who I think is, if they were low intermediate risk and very close to their treatment goal, I would think about PDE5 to SGC just to limit their pill burden or their total medication burden. But if they really aren't close to that treatment goal, if their echo's not close to normal, then I'm going to target another pathway with sotatercept. And now we have such strong data across all levels of risk from Hyperion, Zenith, and Stellar that it's it's just a very effective drug.
That makes a lot of sense. I think blood pressure sometimes also plays into it, that the REPLACE study was not patients on IV therapy. As you were mentioning, it was the switch from the PDE5 to either stay on a PDE5 or to switch. But as we get to these triple therapy patients with an IV agent, a lot of times the blood pressure is just not robust enough to consider riociguat, even if that's what we were otherwise leaning towards.
That's an excellent point. Okay, Guidelines now strongly recommend upfront dual oral therapy for most non-high-risk patients. For those of us in general pulmonology or cardiology, what are the biggest red flags that should make us bypass dual therapy and go straight to triple therapy, including parenteral prostacyclins at the time of diagnosis?
Yeah, that's a great question. I think a subset of patients, it's fairly obvious, and these are the patients who you're meeting for the first time in the ICU, and they're on pressors, and they're in, basically cardiogenic shock from their pulmonary hypertension being so severe. But there are other patients that have a combination of severe symptoms and just really concerning findings on their cardiac imaging and cardiac catheterization. Symptom-wise, the one that always gets my biggest attention is if somebody's having syncope, because that's always a sign that the heart's really struggling with what's going on, and also because it can itself be life-threatening in certain situations. But then also just really looking for signs of RV failure on their catheterization, which is going to be a high right atrial pressure, low cardiac index, and then on echocardiogram, all of the things we talked about today: dilated right atrium, dilated right ventricle, poor function.
Yeah, those are all excellent points. Those high-risk features, right? Someone might calculate out to intermediate risk, but if they have those special high-risk features, you should really consider upfront triple therapy.
All right. Guidelines suggest monotherapy might be appropriate for patients with significant cardiopulmonary comorbidities. In practice, how do we differentiate between PAH complicated by, say, obesity, sleep apnea, versus someone who actually has group 2 or group 3 disease, where PAH-specific therapies might be harmful?
I think this the person who wrote this question clearly has been hanging out in my clinic, probably in your clinic too, Kelly. This is a question that comes up all the time, right? Because so many of our patients with PAH, with real deal PAH, who are diagnosed with it, are older in age and have these comorbidities. They're obese. They may have had a history of CAD. They have risk factors for HFpEF, COPD, et cetera, and it can become very challenging. Um, I find it's helpful to really to use cardiac imaging. I rely on echocardiography a lot, and if the right ventricle is clearly enlarged and has those features that are much more consistent with a PAH type echo than something you see, say like a HFpEF, PH HFpEF echo, when you're looking, because right, you can see those signs on the left side too of the EDE prime and the E to A ratio that can help you differentiate HFpEF from PAH. And then when it comes to group 3 disease, it's a little bit different, right? If someone has some concern for ILD, you might approach that patient differently than doing dual oral therapy. You would think about inhaled therapy if there is a concern about ILD. And for COPD, that's a challenge right now, isn't it, for all of us? But I think it's never wrong to take an approach of rapid escalation of therapy if you're really concerned about it, to see that patient back to make sure they're tolerating one drug and then add the second drug rather quickly. Or you can, you can just closely follow them after adding dual oral therapy to make sure that that you haven't given them a half exacerbation. What do you think, Kelly?
Absolutely agree. I think what to do with the group 3 patients is a big challenge. The ILD patients, yes, we have an approved therapy, but what if it's not enough? And then for COPD, we were surprised, I think, many of us surprised to learn that inhaled Tyvaso was a bad idea. Inhaled treprostinil was a bad idea in those patients. I was going to say, though, that I find the diagnosis part much more challenging, I think, and maybe this is me as a pulmonologist, but the group 2 patients compared to the group 3, that most patients with group 3 PH, it's not subtle. They've been hypoxic. They've carried a diagnosis of COPD or ILD and so on. It's just a challenge what to do with them. But the group 2 HFpEF patients, they come in, I hear I've got pulmonary hypertension. What are you going to do to fix me? And like, yeah. So I'm really hoping that we get some good news as the Cadence trial reads out with sotatercept there, but we'll see.
Okay. we're hearing that intermediate low risk is not truly low risk. For a patient who is functional class 2 and feeling better on dual therapy, what is the best evidence-based argument to convince them and their insurance provider that adding a third or fourth agent is necessary now rather than waiting for symptomatic decline?
That's a great question. I don't often get that your patient's just functional in class 2 and you can't add therapy. What I get is that you haven't tried XYZ, you haven't tried it for long enough, you're at the wrong time point, and those sorts of things. So we definitely have our insurance frustrations. But, I think looking at this intermediate low risk range, that figure from the French registry that looks at not just the 1-year outcomes, but the 5-year outcomes is really what I'm looking at, is that that's a terrible survival rate. We have to do better. I hope we're going to do better. And I'm really will be anxious to see what things look like 5 or 10 years from now. But for now, I'm trying my best to get patients to that low risk range. And I'm sharing those kind of survival outcomes with the occasional insurance company that doesn't want to let me escalate therapy in this type of patient. How about you? I know the insurance question's kind of region specific sometimes. Is this something that you have a hard time with?
Not really from an insurance standpoint. If they're not reaching low risk, it's not an issue. And sometimes, I mean, there is an issue in trying to speak to the patient and telling them about their risk status. I find like showing them their imaging can be very helpful, especially if their right ventricle is still abnormal. That can be very helpful in getting it across to the patients. Like, yeah, you're really not doing much because unfortunately, a lot of our patients are quite sedentary and they might not be so symptomatic.
Yeah, especially I think when our only option for escalation, if they were already on 2 medications or for really serious
Yeah.
escalation, was IV therapy, patients did not want to hear that. They would try to
Yeah.
convince me that they felt better. And I think they did because they had felt terrible before and now they felt somewhat better. And so
Right.
that's where another challenge comes in is, but doc, I'm feeling some better. And so why should I take another medication? All right. When non-invasive markers, NT-proBNP and 6-minute walk, and let's add functional class to that, when these conflict with your imaging or echo findings, which should carry more weight in your decision to escalate therapy?
This is as a cardiologist, I'll just say the imaging is correct. It's largely true, right? Because there are reasons. I think the classic finding, right, is a young patient. We all get scared by these young patients who have excellent 6-minute walk distances because it's greater than 440, and so they're calculating out as low risk. But it's because they have such great physiological reserve. And you look at their echo, and it's a horror show. And it's so you have functional class 2 high 6-minute walk distance patients who are young and they're clearly at much higher risk. And conversely, you have some of these older scleroderma patients who just feel awful all the time. Their 6-minute walk distance is terrible. And when you look at their echo, it's near normal. And you're not going to get much from adding therapy there. So those are, I think, a couple of cases where 6-minute walk distance doesn't help. NT-proBNP tends to be correlate pretty well with hemodynamics and echo, but there are some places where it doesn't, especially in obese patients, where it can be artificially low. So that has to be kept in mind. What do you think, Kelly?
Yeah, no, that makes sense. And I was thinking about the NT-proBNP. It's if I had to put my money on a single non-invasive one, it would be that. But there is that every once in a while patient where it just doesn't seem to be in line with everything else. And so it's looking at the overall picture.
Okay, looks like we have time for one last question. Given that maximal medical therapy is now considered 4-drug combination therapy, at what point in the escalation process should a formal transplant evaluation occur? Should we wait until they fail quad therapy, or should the referral happen the moment they hit the intermediate high category on triple therapy?
That's a
Good question.
great question. This was one of the most controversial topics at the last World Symposium on Pulmonary Hypertension. I'll tell you what the transplant doctors think. They think from the beginning, anybody hits an intermediate high or high risk no matter what therapy they've been tried on, they want them in transplant clinic because they see the patients where we missed the window. And that can happen relatively quickly if they develop renal dysfunction or they've had RV failure for too long and their liver is not looking good enough, or a million other things happen. We may miss the window where they're eligible for transplant. This question, I think, is fairly center and region dependent. I have the advantage of my clinic being physically in the transplant clinic. We're all in the same clinic, so I already know they've tackled the insurance problem. But I think an earlier referral, once you've hit that, maybe not at diagnosis, but at first follow-up after 2 or 3 medications and they're still in this range, we should really be thinking about referral. Referral is not the same as listing. This is going to be looking for potential barriers should transplant become necessary, but not necessarily going straight to listing. What does your center do?
Very similar. And it's a great point you made. It's a long process with transplant. They need to get to know that patient, all these social evaluations, everything else. You need to give that a lot of time. Now, of course, in Zenith, we saw that the rate of transplants, after sotatercept was added, went from, it was 8 in the placebo group to 1 in the sotatercept group. So clearly you're avoiding a lot of transplant there, but you can't count on it. And it's better to do right by your patients and, refer them early.
Great answer.
Okay. Okay. Thank you for those questions. Unfortunately, we've run out of time, but we'd like to thank you so much for joining us. Importantly, again, now you see the QR code for today's session. You'll need to scan this to claim your CME certificate, which is completely free. This will also be placed as a link in the chat box. Well, I hope you found today's session helpful and interesting. It's been a real pleasure to host you. If you enjoyed this session, please be sure to check out our other resources on medalleducation.com. That's medalleducation.com, where you can claim CME credit for participating in all our free CME programs. Thanks again for joining us.